Olá, boa noite. É, Meu nome é Alberto de la Veiga, eu sou cirurgião de tórax, e eu que vou moderar esse webinar, que faz parte do mês de conscientização sobre as neoplasias tímicas, que tem sido organizado pelo ITMIG, e já é a segunda vez que nós fazemos esse webinar em português, com a participação de membros do ITMIG. E para começar a apresentação, eu vou convidar a doutora Jeane Ackman. Dr. Chen is a thoracic radiologist at Massachusetts General Hospital and an associated professor of radiology at Harvard Medical School. Dr. Chen, thank you very much for accepting our invite.
Oh,
Please, you can
an
start.
absolute pleasure. Thank you for the invitation and really happy to have the opportunity to share this information. Shall I share my screen?
Yes, you can.
Okay. Here we go. And we'll hit play. Here we go. I think I'm going to move the Zoom uh, picture here so that we can see everything that we need to see. So I'll be speaking about pre-surgical imaging evaluation of suspected thymic epithelial tumors. Can everyone hear all right?
Yes.
Great. Okay. Okay, so sorry, a little slide advancement issue. Let me just okay, here we go. Here are my disclosures. I'm going to demonstrate what MR offers beyond CT and PET for evaluation of thymic lesions in terms of tissue characterization, soft tissue contrast, and thereby added diagnostic specificity. In essence, MR offers a non-invasive, non-irradiating virtual biopsy in many cases. It can also assist with intervention or surgical guidance, offering the optimal site for diagnostic biopsy and informing surgical approach. It can also provide free breathing dynamic evaluation of various anatomic structures and show the relationship of a mass to the chest wall dynamically. Why is this important? Because historically there has been a high rate of unnecessary thymectomy on account of the fact that on CT we can often misinterpret benign thymic lesions such as cysts and hyperplasia as thymic tumors. And that's what we found in our study of all thymectomies that we did at MGH between 2006 and 2012. 26% of cases were unnecessary thymectomies, mostly due to resection of thymic cysts and thymic hyperplasia. I just want to also just emphasize, though, that research has shown that in some cases, even excision of normal or hyperplastic thymus, um, or even normal thymus, not just hyperplastic or tumors, can improve symptoms in myasthenia gravis, as per the New England Journal of Medicine article in 2016. I'm now going to share a tale of three thymic nodules with you. These images come from three patients with three similar appearing thymic nodules on CT, but three different diagnoses. One lesion measures 28 Hounsfield units, another 47, and another 39. They're all well circumscribed for the most part in the prevascular mediastinum. What's the differential diagnosis? Thymic cyst, thymoma, an enlarged lymph node? Maybe not. If there's no lymphadenopathy anywhere else, a solitary prevascular nodule is unlikely to represent a lymph node. Here's patient number one. The lesion measured 28 Hounsfield units on CT, and we can see that it is T1 hyperintense to the chest wall musculature, T2 hyperintense, and shows no internal enhancement, just some thin, smooth wall enhancement. Notice we cannot appreciate these features on the CT. So this is a thin wall, benign unilocular thymic cyst. It does not need to come out. What about this lesion? It looks pretty much the same as the other. It was T1 isointense to muscle, T2 hyperintense, but in this case, it showed rapid time to peak enhancement at 20 seconds with some washout over time. So this was a thymoma, not a thymic cyst. Here's the third patient. The lesion in that left prevascular or mediastinum or thymic bed was stable. By CT, 12 months later, it looked identical. It measured 39 Hounsfield units. So what is it? Luckily, an MR was ordered. In this particular case, it was both cystic and solid. And in fact, it had a regular thick wall enhancement, particularly on the left lateral side of the lesion. So this is a cystic thymic epithelial tumor until proven otherwise, and it turned out to be a cystic thymic carcinoma. So again, we had three thymic nodules on CT, pretty much all looking the same. One was um, a benign thymic cyst, another was a thymoma, and another was a cystic thymic carcinoma. Here it is the latter lesion on the table after surgery. We're going to journey through a bunch of other cases to see how different imaging modalities perform in evaluation of thymic masses. So here's a 71-year-old man with a history of multiple myeloma and thrombocytopenia. We can see a lytic lesion in the left lateral rib with some cortical breakthrough and a soft tissue mass, but we also see a large right thymic mass. So what is it? Is it really a mass or is it something else? It measured 52 Hounsfield units. 3 years earlier, it wasn't there. What's its differential diagnosis? Well, it could be hemorrhage in the setting of thrombocytopenia. We've seen many cases of spontaneous thymic hemorrhage in normal and hyperplastic thymus, and that can really confound us, our interpretation on CT. Thymic hyperplasia in a more mass-like form, thymic epithelial tumor, lymphoma. What is it? Here are matched MR images to this CT image. We can see that the lesion is marked in T1 signal. It's very T1 hyperintense and very T2 hyperintense, but for some areas of internal isointensity. Pre and post contrast images show, well, what do they show? Is a lesion enhancing or not? Even on MR, it can be tough if a lesion is intrinsically T1 hyperintense. But we can put ROIs on the lesion to look for enhancement. But better yet, we can get automated post-process subtracted images. And in this case, we can see that the lesion almost doesn't enhance at all. There's just some peripheral rim enhancement and there's some thin wisps of enhancement internally. But the vast majority of the mass does not enhance. And therefore, we deduce in the setting of thrombocytopenia that this was spontaneous thymic hemorrhage into the thymus. The enhancing tissue is probably thymus and or some reactive inflammation. And we watched this lesion disappear. 4 months later, it was gone. Unfortunately, the myelomatous lesion in that left rib had increased in size. So this highlights the value of post-contrast automated post-process subtraction MR, particularly
Mira,
for intrinsically
yo
T1
pensé que nos
hyperintense
estaban
lesions.
mirando.
Sorry? Uh, um, and this particular technique is widely available on virtually all MR scanners out there. We just need to do dynamic contrast enhanced imaging in order to uh, get these subtraction images. And we've been doing dynamic contrast enhanced imaging in the liver for decades now. We can do it in the chest as well. So it can help with determining vascular or avascular areas and lesions, cystic or solid, fluid or cellular content. What about this 22-year-old man with Graves' disease? He has excess thymic tissue. It's biconvex. It looks like it's bilobar as well. So this could well be thymic hyperplasia, especially in this clinical setting. And an MR was requested because we couldn't be sure that this wasn't an early lymphoma, for example. And the MR showed on the in and opposed phase imaging that there was qualitative suppression, especially of the left half of the lesion, and that there was therefore microscopic fat in it, and therefore at least that part should represent some thymic hyperplasia, not tumor. But what about the right half of the lesion? We can't see qualitative suppression here, but if we put ROIs on the lesion, we could see that there was 14% signal dropout, which is more than needed, more than the 9% signal suppression needed to detect to prove the presence of microscopic fat. So all of this lesion was thymic hyperplasia. It does not need to come out. This 22-year-old man had a fever of unknown origin and went straight to PET scan. There was this very FDG PET avid prevascular thymic tissue. So Is it tumor? Is it lymphoma? Or is it just normal or hyperplastic thymus? Well, even for a 22-year-old, this may be a little bit too much thymic tissue for age, outside limits of normal. And what about that SUV max of 3? Are we worried? And the answer is no, because normal thymus and hyperplasia can be very FDG PET avid. So PET can really confuse us and is if at least if we're just evaluating a thymic lesion, probably shouldn't be the first modality we go to. In this case, this was an incidental finding. You can see suppression on a post-phase imaging, 24% signal dropout, and that this lesion again is either upper limits of normal thymus or hyperplasia, depending on if the measurement. And I think it was about 22, so it's on it. So it's too much tissue for age in terms of millimeter thickness. So this case highlights the hazard of FDG PET imaging for thymic evaluation. This 39-year-old woman also had Graves' disease and had excess thyroid tissue, and an astute sonographer noticed excess thymic tissue in the retromanubrial space. Patient was referred directly to MR bypassing CT because that's actually a wasted use of a study, given that CT was unlikely to be diagnostic. The MR showed too much tissue for age with a maximal thymic lobar thickness of 25 millimeters, greater than the what would be expected, maybe more like 13 millimeters in this age group. Also, there's too much soft tissue for age, but it did not suppress on a post-phase imaging. So what do we do? It looks bipyramidal. It looks like hyperplasia. It's the right clinical setting for it, but we're not getting suppression. Well, we have one more tool in our tool chest on MR that we can use both in children and adults in this setting, since non-suppressing thymic hyperplasia can exist not only in children but adults. I just show you this image to highlight how not just tumors, but hyperplasia can enhance. And I want you to remember that on MR, we can appreciate the enhancement of normal and hyperplastic thymic tissue, not just tumor, because of its higher soft tissue contrast. Differential diagnosis in this case so far is thymic hyperplasia that's not suppressing, a thymic epithelial tumor or lymphoma. But our added tool is diffusion weighted imaging. And this breath hold diffusion weighted imaging yielded this ADC map and an ADC value of 4.0 or 4.1, which is essentially the ADC value we'd expect for water. So there was no significant restricted diffusion in this tremendous excess of thymic tissue for age that's rather mass-like, although bipyramidal. And therefore, this must be hyperplasia, not lymphoma, and not a thymic epithelial tumor. So again, non-invasive diagnosis, no surgery needed. So this case highlights the value of the ADC map in the setting of non-suppressing thymic hyperplasia. And again, this does exist. It's been reported in the literature. This 60-year-old man was undergoing routine oncologic CT surveillance for lung cancer and had this enlarging prevascular mediastinal nodule in the retromanubrial space. In 2013, the enlargement triggered a request for MRI. The MR showed the lesion to be a cyst. Note the lower right image showed no internal enhancement, just smooth wall enhancement. Although the wall is a little bit thick, it actually measured 4 millimeters in thickness. So we do need to follow this to be sure it wasn't an early cystic thymoma or cystic thymic carcinoma, for example. The lesion didn't suppress on a post-phase imaging, so it wasn't a dermoid cyst. Over time, we watched the lesion involute. So by 2015, it was barely discernible from the retromanubrial musculature. So these thymic cysts can fluctuate in size, signal, and attenuation over time. And as we proved in this longitudinal study of unilocular thymic cysts, it was a retrospective study, but we were able to show this. 98% of these unilocular thymic cysts showed thin, smooth wall enhancement on MR, which we cannot appreciate on the CT on account of the lower soft tissue contrast. And that wall measured 2 millimeters plus or minus 1. So again, if the wall measures greater than that, you want to, but it's super smooth, there's no mural nodularity or septations. You can consider short interval surveillance by MR and look for any change that might trigger surgery. Or if you're really worried, obviously take it out. Why do these lesions fluctuate in size and MR signal and CT attenuation over time? We showed that many, at least the resected specimens that we had in our pathologic database showed intralesional microbleeding in the resected tissue. And so basically, these lesions can spontaneously hemorrhage and resorb. And when they hemorrhage, they get bigger. When they resorb, they get smaller. And we don't care about the increase in size, provided that that increase is all fluid and not the wall thickness. So remember, thymic cysts may have CT attenuation values as high as 100 Hounsfield units. That case I just showed you was a case of a thymic cyst measuring 97 Hounsfield units. Lesions can change in size, CT attenuation, and MR signal over time. Therefore, interval enlargement and/or other above described changes in and of themselves do not signify malignancy, but if we see development of irregular wall thickening, mural nodularity, and/or enhancing septa, it may indicate malignancy. It usually does. This 58-year-old man with benign positional vertigo had a neck CTA, which showed an incompletely imaged mediastinal mass. So he went to chest CT, and this is what we found. So we have a large thymic mass centered in the left side of the thymic bed. What is it? It was not attached to the thyroid gland. It was compressing the left innominate vein. Could it be hemorrhage, thymic hyperplasia, thymic epithelial tumor, or lymphoma, or something else? The lesion showed marked T2 hypointensity on the corresponding MRI. That's a big clue that this is not a thymoma or lymphoma, which should be T2 hyperintense. Also, it did enhance, and although in a very delayed, gradual way in the most fibrous areas, did not enhance very much at all. That low T2 signal with delayed enhancement indicates fibrous tissue. So this is a very fibrous mass, most likely a thyroid goiter. The only other thing that we might think about would be a solitary fibrous tumor of the pleura. Could it be chronic fibrosing mediastinitis? Well, one big focal mass like that may be a bit less likely. The patient was nervous about leaving it in, as was the surgeon, so it was taken out and proven to be a goiter. But we were able to make that non-invasive tissue diagnosis, and one could have made an argument for watching this lesion if it wasn't bothering the patient. The compression of the vein raised offered a reason to do surgery, however, in this particular case. So this case highlights the value of MR, again, for tissue characterization and the potential for prevention of unnecessary thymectomy, and also the possibility of surveillance without ionizing radiation exposure when uncertain. What about this incidental? We found lesion on chest x-ray that led to this CT. We have a right thymic mass. Is it cystic, solid, both? What's it made of? Well, the matched MR images show suppression on a post-phase imaging of some of the liquid within this mostly cystic lesion. Note that lower right image shows mostly thin, smooth wall enhancement, but some irregular wall enhancement, a septation that enhances in it, but most of it is fluid, and we've proven fat in the fluid, and it's in the prevascular mediastinum. So the diagnosis should be a dermoid cyst, which is what this turned out to be. This 54-year-old woman had a history of carcinosarcoma of the ovary and a rapidly enlarging prevascular mediastinal mass. It had a saccular morphology, it had homogeneous attenuation, and it measured 11 Hounsfield units. So could it be an acquired thymic cyst? It sure looks like one on the CT, but it wasn't. On MR, it was shown to heterogeneously enhance over time. So this was not a benign cyst. This was tumor. And in the setting of the ovarian cancer, it turned out to be a myxoid pleomorphic sarcoma in the thymus. So remember that not every thymic lesion that looks solid on CT is solid. It may be a benign cyst. Not every thymic lesion that looks like a cyst on CT is a cyst. And not every thymic lesion that suppresses on MR is normal thymus or hyperplasia. It might be a dermoid cyst, for example. So we have to look at the MR signal, the morphology, and behavior over time and correlate clinically before we make any decisions. Finally, in terms of case studies, I show you the 67-year-old female smoker with incompletely imaged prevascular mediastinal mass on coronary calcium scoring CT. Looks like a cyst. In this case, it was a cyst on MRI. Note the lack of restricted diffusion, not that we needed that. There was no internal enhancement, just some thin smooth wall enhancement, and there's a little misregistration on the subtracted image there, but this was a benign unilocular cyst. But in the same patient higher up, look what we found in that left upper lobe, a spiculated nodule with low ADC value, with a low ADC value of 1.2. So this is a very malignant appearing lesion in the left upper lobe, incidentally found during a thymic MR study. And so it just highlights the importance of looking at all four corners of every image to make sure that we're not missing something else that could have a bearing on the patient's prognosis. This was detected early enough that hopefully the patient underwent a surgical cure. So look everywhere, even in the lungs. MR can detect 100% of thymic nodules greater than 8 millimeters with certain pulse sequences that are widely available. So please keep that in mind. So thymic lesions can be tricky. MR can sort them out and more precisely guide clinical management in many cases. Just some further displays of surgical guidance by MR. Here's the so-called MR sniff test. Yes, we can do a fluoroscopic sniff test, but you can't beat this for showing the relationship of the mass to the phrenic nerve and the paradoxical motion of that left hemidiaphragm all in one study. And this is just a free breathing, non-contrast study, just bright blood technique. It took 30 seconds to do as part of an MR evaluating the thymic lesion. Same thymic carcinoma. The surgeon also wanted to know if it was invading through pericardium. And you can see, indeed, it is invading through that black line of pericardium further into the mediastinum. Unequivocal assessment that we couldn't definitively make by CT. The same MR sniff test can also be used to evaluate invasiveness and whether a lesion stuck to the chest wall. This was actually a solitary fibrous tumor rather than a thymoma. Note it's more, in this case, it was more posteriorly located, but that doesn't matter. I did just want to highlight how we can use the same tool to assess whether a lesion stuck to the chest wall. This came out very easily, and the surgeon really appreciated having the heads up about that. MR can better assess the extent and location of pleural disease, including thymoma drop metastases, not just mesothelioma. On CT, this thymoma drop metastasis is isoattenuating with the adjacent chest wall musculature. Where does it end? How big is it? By T2 weighted imaging, which is non-contrast, as well as the post-contrast image, we can better define the mass from the adjacent chest wall musculature and say that in addition, not so much by CT, but by MR, that it's splitting the diaphragmatic leaflet apart. The diaphragmatic leaflet is low in T2 signal, it's skeletal muscle, so it's lower in signal than the tumor. And so we can define it and see that the tumor is invading right through it into the belly and into the extraperitoneal space of the abdomen, as well as into the chest wall. See that lower T2 weighted image and the lower the post-contrast image. There's also a pararenal metastasis that's harder to see by CT, but we could go right by it, but it's there. These are just close-ups of the same thing. There's the tumor splitting the diaphragmatic leaflet apart. We showed on a prospective study that MR increased diagnostic certainty and reduced the need for intervention for our thoracic surgeons in a significant manner, provided unexpected relevant diagnostic information in 2/3 of cases, and changed or modified the diagnosis in nearly half. It reduced the need for patient follow-up by 21% or more if we weren't following the thymic cysts. It modified the surgical approach in more than half of cases and increased thoracic surgeon comfort with patient management in nearly all cases. So why is MR invaluable for pre-surgical thymic mass evaluation? Many masses that look like thymomas on CT are not thymomas, and some don't need a biopsy or surgery. MR can distinguish them non-invasively and also further guide the surgeon when surgery is needed. Here are my references. Thank you very much for your attention.